important warning. So what's important to, why do we need to know about a TIA? Because
It could lead to a
so what are we doing as a nurse? Just saying, oh, you're gonna have one day, go ahead, go.
Education.
What kind of new ways are they gonna adapt to?
Do you need a water bottle?
Diet, lifestyle,
Thank you.
cholesterol, what kind of medication?
Like maybe their diabetes.
Diabetes,
From the back.
compliant with their diabetes.
Do you give TPA for TIA?
No.
Non-contrast CT. Will it show?
Blood thinners, it depends on, is it from AFib, because then you wanna put them on anticoagulants, exercise.
So if a patient comes into the ER with like stroke-like symptoms and it really is a TIA, how do we know that it's a TIA? Should we still get TIA?
So if they're still having if they're still having symptoms like in the emergency room and past like that 15 minutes, they don't have any symptoms resolved, then they'll start TPA as long as it's not a heavy leak. So usually usually the few minutes with the TPA, most errors on the TPA is within a few minutes those symptoms resolve. But they say within a few minutes to 24 hours. Weakness on the right side is on the left brain stroke, and vice versa.
Left side is the logic side, right side is the left side.
Left side is the logic side, smart side. I worry more what's going on in the lobes, right? We need to know what's going on in the lobes. Intracranial pressure, tell me about that.
When you have the Montrose-Kelly hypothesis,
The earliest sign is decreased velocity.
Okay.
Elevates head of the bed, 30 periods.
Head of bed, 30 degrees. What are their symptoms?
less contraindicated.
Low respirations, low pulse,
We have to manage.
and high blood pressure. They are. All those are. What's that called? Cushing's triad. High blood pressure, extremely high blood pressure, low pulse, low respiration. Opposite of shock. Opposite of shock. What else?
There they sent around the sign-in sheet. I don't know where it's at.
That's just a
Feel good. I woke up with a sore throat.
No, me too.
Yeah, something's going around.
Yeah, I don't know what it is, but it sucks.
I tried to get some tea with lemon.
All right, TPA, do we need to go over TPA or do we have it? 4.5 hours. Do we need to go? Really?
Make sure you have 2 hours
All right.
Before you do it.
before you do it. And know it lines after.
And you know what?
No, like, other lines before you.
Is that nice to know stuff or? We had this discussion yesterday. Nice to know stuff. What's the most important things to know about TPA? 4.5 hours, bleeding. We're going in and we're anticoagulating everything. What? What about contraindications?
Above 80 years old.
They need that again.
Everybody aspirin or anything already, is that a go or a no?
Any,
Over 80.
Any major surgery, because what's gonna happen, I just had an abdominal surgery, and now I'm having a stroke, and now I'm getting TPA, and now my wound is opening up, and now I'm bleeding out, and I'm gonna die.
Over 80.
Over 80, I'm not over 80. Something else, there's one other thing, yeah, hemorrhagic stroke,
INR.
INR, 1.7 has to be over. Okay. Anything else? Autonomic oh, there's one other thing. What about why, we said the 4.5 hours, why are we not giving CPA past the 4.5 hours?
It's too damaged.
Risk versus reward, the damage is done. All we're gonna do is increase more damage or more risk factors. It sounds harsh, but it's. All right, what's autonomic dysreflexia? What kind of injury did they have? Spinal cord injury. So what is happening? Where is the miscommunication with autonomic dysreflexia? It's kind of in the name. And I just realized. The autonomic and the parasympathetic, well, it's in the autonomic nervous system. There's miscommunication between the sympathetic and parasympathetic nervous system. Because one is saying, hey, you got to vasoconstrict, but that message is not getting it. Or vasodilate. Is that an autonomic dysreflexia? So what's the problem with autonomic dysreflexia? What is the patient experiencing? Not diaphragm. Wait. What's happening? We
Can I
have to
get that when you're done?
investigate. So I'll tell you a story. I had a student, I think I told you this.
Oh.
I had a student in clinic. I'm afraid about this. So I had a student in clinical once and extremely high blood pressure. And so the nurse and the student are kind of getting involved in whatever. They need help. They didn't really need help, but I was getting involved because students was going to start doing some IV pushes of hydralazine and whatever. So I go in, the guy's face is red, he's sweaty, and then, I don't know why, but we took the blankets back, and he's got these tiny little white legs. And if you've seen like a spinal cord injury or something like that, there's like no muscle development lower extremities. So I'm like, something's going on here. This picture doesn't make sense. Well, come to find out, he was in a motorcycle accident 20 years ago. So he was experiencing autonomic dysreflexia. His bladder was full, so we emptied his bladder. His blood, but he was like pale legs. It was totally textbook situation. And we emptied the bladder. We did give him some medication. But we sat his head up first because his blood pressure was high. And then we investigated. So other issues with the bladder with autonomic dysreflexia, there's a couple of other top causes. Fecal impaction, so that means you gotta go up and find it, see if there's anything in there. Hypertension is a medical emergency. So because their blood pressure is so high. What did you say? Oh, you said it?
I said restricted clothing.
Oh, restrictive clothing, you're right. Both of you are right. Restrictive clothing, full bladder, fecal impaction, pressure areas, any skin issues or anything like that. Okay? And do I what? Skin, like the pressure area. Maybe they got an ulcer on their butt. Some on their left cheek, some on their right cheek. Healing, dressing, yeah. I mean, it
Well,
would,
I mean, like draining the bladder, that's immediate.
right, right.
I was thinking you can't really feel the way.
Well, you could treat it. You could treat it and stuff. Okay. Do we need to talk about neurogenic shock? Because it's already 14 after 9. What are symptoms? What's neurogenic shock? Everything's down. Everything's down. Respiratory rate, blood pressure, because it's shock, remember. So this time the blood pressure is down. What caused that neurogenic shock? A spinal cord injury. So, okay. UTI, does that, how could that, for what? Sorry. What do you wanna know about the UTI? What could it cause? Dysreflexia, yeah, I thought you were going into shot. Because what type of shock would they be at risk for with UTI? Septic shock, yeah. Okay, we okay? Any questions about last week? Yeah, there are some. Okay, why, we go into back pain mainly because it's the spinal cord, but there's a difference between acute back pain and chronic back pain, and what I really wanna hone in on the back pain is really the surgical, measures for back pain. But there's a couple different types of back pain, the herniated disc, lumbar disc, and, degenerative disc disease. There's always the type of, I think you'll know what I'm talking about if there's a question on back pain. But the pain, depends on where the location is in the back. If it's in the lumbar puncture, is it in the thoracic, it really just kind of depends where the pain is and where that bulgy disc is or whatever. Prevention is your best measure, so ergonomics, you'll have to do competencies every year, wherever you work, at how to lift, keep your back aligned, make sure you do good ergonomic posture, exercise, make sure you wear low heel shoes, healthy weight, no smoking, all preventative measures. So there's non-surgical management the first one's acute low back pain, which is you could do Tylenol, firm mattress, Williams position, where you're getting the pressure off the lower back. So they might be laying flat with a pillow under their knees just to take the pressure off. Chronic low back pain, you might gabapentin. If you see that for any kind of neurological problem, gabapentin, I figure is ordered. We see that a lot. We saw it actually yesterday. Heat therapy, physical therapy, weight control, and any kind of complementary alternative therapy. They even talk about chiropractic therapies. I tell people not to go to a chiropractor.
I would. I said I just got off my 6 weeks of treatment. I don't feel like I was feeling, because I had an accident on the 27th of August,
Yeah.
and I ended up just going 2 weeks after. I feel like something just pushing me down on my shoulders, my head,
They lengthened it?
my neck. I don't know what he did, but he did
It
something.
worked?
Yeah. It's not, but he did an x-ray and he said I had disc 6 was like not good.
Oh, really? Biggest thing, gabapentin, I would say, and then the Tylenol. What is our max for Tylenol? 4,000. So we gotta always pay attention to those numbers. So there's 5 different surgical incisions. I think if you see an ectomy, you'll realize it's a surgical or removal. Yeah, you'll recognize that it's a back surgery. I'm not. You'll see an otomy, and then they have that. If you look at the back or the last part of the word, they all have ectomy. So laminectomy, microdiscectomy, and all that. But what's important to know is the care post-operatively. So because they're having a spinal cord surgery, we want to make sure we're doing those neurovascular assessments. We're checking the calf refill in their toes. We're checking, can they move their toes? Are they warm and tingly? Or are they warm, not tingly, no pain? So do those neurovascular assessments, check those pulses. We're monitoring that dressing. So because it's in the back, we're looking for cerebral spinal fluid. Is it just clear drainage, or does it have a halo? If it has one of those, we need to make sure that we're checking it for glucose, because glucose is not stored in the cerebral spinal fluid. Log roll the patient, so we wanna keep body alignment, so usually there's more than 2 people. But log roll, pain control, patient positioning and mobility. There's strict instructions on, when they get discharged. It usually depends on the type of surgery that they have, and, just kind of, for post-surgery, we're worried more about this. Can they avoid? Do they have control of their bladder and, are they able to avoid? Post-education, they'll usually, if it's a minimal invasive surgery, they can usually resume activities in a few days to up to a couple of weeks. 3, shower in a couple days. Usually they have steri strips on there. We tell them not to remove those steri strips to keep the incision closed. Keep them in place, they'll fall off eventually. And then if you see clear drainage, make sure that they're contacting their surgeon immediately. Conventional open back, this is more an invasive surgery where they might have driving or activity restrictions for a few more weeks, like 4 to 6 weeks. Limit daily stair climbing. So if they have bedroom on the 1st floor or on the 2nd floor, they might need to move downstairs for a couple weeks. Restricted driving, do not lift heavy objects, more than 5 pounds. Restrict pushing and pulling activities, even something as minor as walking a dog. Because if you think about it, you're walking a dog and the dog takes off, you're getting pulled forward, especially if it's a bigger dog. Avoid bending and twisting at the waist, and then take daily walks, keep moving. But you've gotta monitor your alignment. And with post-operative education, twisting and bending at the waist is really enforced education-wise with back surgeries. Okay, I'm gonna do a couple more questions after each content. So a nurse is admitting a client to the surgical unit 2 hours after a laminectomy. Blood pressure is okay, heart rate's okay, respiratory rate, 5 out of 10 pain, that's not bad. Surgical dressing is clean, dry, JP is in there, 15 milliliters of serous sanguineous fluid. What new assessment finding requires the most immediate action? 8 out of 10 pain, toes. The client's toes on the right foot have delayed cap refill of 4. The nurse notes surgical dressing is now damp with clear yellowish fluid. And then the client reports difficulty moving the big toe and decreased sensation on the top of the foot. So what are all of these problems?
Yeah.
So cervical spine fluid leakage, that's probably C. Decreased cap refill means they're not getting perfusion, but also the big toe, all of it means difficulty with perfusion. So the answer is actually D, just because there's lack of perfusion. There might be swelling at the surgical site, so we need to address that first, and then you can address the rest of it. So this means that they have no sensation or anything, or they're losing sensation in that foot. I know you're like, pardon me? Well, cap refill, that's perfusion blood-wise. Do you see cap refill? C is, wait, what did you ask? Oh, B and D?
Yeah, B and D are both like.
Cap refill, that's not a big difference, but if they're losing sensation, they're losing like sensory and motor function. So that's telling me that something is cut off. There's a lot of swelling that's cut off. I wouldn't give you a test like this, but I just want you to think through the question. I know, this is a hard question. Because now they're all critical except for the pain. They're all critical, but what's the most critical? I got this from ATI, that's what I did. All right, the nurse is caring for a 3-day spinal infusion. The nurse knows that the client's temp is that site warm. Which complication would you expect? Yeah, that's easy.
Infection.
Because what are the if you were suspecting a DVT, what are you gonna expect to see in your assessment? Swelling in the leg, like pain behind the knee, redness behind the knee. Spinal cord edema would probably be D on the other question. And what about spinal cord leakage? Spinal cord fluid, CSF leakage is looking at the dressing. So recognize those complications because we'll have a question like this where it says, hey, temperature is this, maybe white blood cells are this, and or you're testing surgical dressing and you notice and you tested for glucose. So we're gonna give you the explanation, but you have to figure out the answer, which that one would be easy, which would be leakage of the cerebral spinal fluid. If it was a glucose. No, we're not testing the number, good question. We're not testing how much glucose. You know the dipsticks for urine that test for glucose? Those just test if there's glucose in the urine. We're not testing the number for glucose. So we're just testing if there's glucose. So you just put a little strip on there and on the dressing and let it absorb the fluid. And it will notify you of any kind of glucose. So which statement made by the client 1 day post-laminectomy indicates further teaching is required? So post-op. So my spouse can lift and move my legs to help me get out of bed more easily. I will be careful to keep my spine straight and log roll technique when I turn. I will ask the nurse to help every time I will get out of bed. I should not bend over to put on my shoes or twist my body. So which one, what, are we looking for the right answer or the wrong answer?
Wrong.
So the wrong, because which statement indicates further teaching is required? So look for those key words because we'll say it like that, or when would the nurse intervene? That's the other way we'll say it. No, it's called critical thinking. So read those questions. If you're going through, you're right, it's A because B, C, and D are what we don't want to, are what we do want to do. If you're going through a question and you're like, well, that we know that's wrong, but B is right, C is right, D is right, go back and read the question because you probably missed that indicates further teaching. Because there were a lot of students that I did meet with, they do forget, they do miss, they read the question too fast, and they miss what is indicates further teaching. Okay, are we good on back pain? I think we're good on back pain. We're gonna move on to meningitis. So this inflammation of the meninges that cover the brain and the spinal cord. It's usually caused by infection or virus or something like that, but it does cause increased intracranial pressure. So risk factors for viral meningitis using just aseptic issues, measles, mumps, herpes, arbovirus, which is a West Nile virus, fungal meningitis, septic, meningitis, immunocompromised. If you lab personnel, think about all the people that are testing that cerebral spinal fluid. They need to be diligent about their safety precautions when testing things. Military, traveling to areas where they have a high population of meningitis, and then overcrowding living conditions are risk factors. So your symptoms of meningitis: headache, fever, nuchal rigidity. Nuchal rigidity, it hurts when they cannot put their chin to their chest because it hurts so much. Altered level of consciousness. Do those look familiar, confusion, disorientation, lethargic because of the increased intracranial pressure. Positive Koenig, Rudinsky sign, that will be the next slide, we'll talk about that. Photophobia, sensitivity to lights. This red macular rash, I joked today that if it was Halloween, I was gonna come with the macular rash on my face. Because I'll tell you in a minute. Restlessness, irritability, seizures, and then cranial nerve dysfunction. So here are the reflexes. So this first one to the top left is the Babinski reflex. So normally, an adult, you stroke the sole of the foot and our toes don't flare out. Usually between the ages of newborn to 2, their toes flare out. That is a normal reflex. And if that happens in the adult, that's an indication of meningitis, one of the tests. Rudinsky is another one where they're laying down, they put their chin to their chest, and their legs bend up. Their legs will bend and come to their chest. The other one is Koenig's, where the patient is laying flat and you lift up their leg and try to straighten it out like in the picture, but it doesn't, it's too painful and the patient can't do it. And it's all because of the spinal cord inflammation. It's too painful for them to stretch their spinal cord, and that's why they're having the pain. There's a patient that, well, there's 2 patients recently that I was talking to one of the nurses last night, and she said that someone within the last couple months came in and it was suspected, and they were doing like the Koenig sign, and they were trying to, how do you suspect it without doing a lumbar puncture, or how do you test it? So they were going through all these signs. And then we had another person yesterday that it was suspected, but they still didn't do a lumbar puncture sign because you need to get that fluid to test it to confirm it. They were at droplet precautions, yeah. We'll get into care, nursing interventions. Any question about these signs? You will need to know these signs. Diagnosis. So diagnosis with bacterial meningitis, because bacterial meningitis is a medical emergency. So we really need to identify it as soon as we can. Take precautions. We're going to take precautions no matter what. But with their cerebral spinal fluid, it's cloudy. They have elevated white blood cells. They have elevated protein, decreased glucose in it, and then elevated cerebral spinal pressure. Oh yeah. Then you could do viral or protozoa. You could do some testing to see what kind of bacterial or fungal items are in there. CT, MRI, because you can see is the intracranial pressure from an abscess or what is happening within the brain. Cultures, we need to do that. We need to check urine, nose, and throat because you're kind of ruling out other causes. And then you'll look at the CBC. There's one more. Chest x-ray. You're looking into sinuses and all that. Usually catheters that have hooked up, like, I don't want to say it's like blood pressure, but when you are testing intracranial pressure, they have special catheters that go in and can measure the pressures within the brain. Yeah, kind of like an arterial. So the difference between viral and bacterial, viral is more common. Turn that off. I heard a ding. Is it my phone?
Yeah.
Was that my phone? Gonna get heat. I haven't had heat for days. My husband do that. So viral meningitis, that is most common. And with viral meningitis, we're going to treat the symptoms. Remember we talked about viral pneumonia. You're just treating the symptoms because it's not caused by bacteria. So the cerebral spinal fluid has no organism in it, so there's no exudate. So it's not, the cerebral spinal fluid is clear. And like I said, we treat symptomatically. When it gets into medical emergency bacterial, it is caused by an organism and it does increase intracranial pressure. Because there's exudate, I wanna say it's like pus that's in that cerebral spinal fluid. So to test that cerebral spinal fluid, we're gonna do a lumbar puncture. A lumbar punctures is they're gonna put in a catheter or a needle into the area, but usually between 3 and 4, L3 and 4. They're gonna put it in the fluid and draw back some of the fluid. I don't wanna say operatively, but pre-procedure, keep the patient NPO. Sedative can be given. Have them laying on their side like this sideline position. You want their back hunched over because you want to open up that spinal cord cavity, or they can kind of be sitting up and leaning over the bedside table. There's two different ways. Here, the knees are to the chest. Have them empty their bladder, because if you empty their bladder, they can get hunched over a little bit more. Post-operatively, we want their head of bed usually below 30 degrees for 3 to 8 hours. So they're lying flat usually for up to 8 hours because we don't want to manipulate that where they inserted that needle to get the cerebral spinal fluid. Have them drink plenty of water, plenty of fluids, and always monitoring vital signs and urine output. A complication of lumbar puncture is a headache, and that headache is from the decrease in cerebral spinal fluid. But the more fluids that they drink, it should regulate itself. If you have any thought that a lumbar or someone has intracranial pressure, that lumbar puncture is going to be not done. And that is a nursing, we're the ones that are gonna be the first ones to recognize it, so we need to notify the doctor. That'd be something that you notify the doctor and say, I'm having questions about this, because the patient is restless, they're irritable, or they are showing signs of intracranial pressure. So you don't wanna do that, because if there's pressure already within the brain, and you're going into that spinal cord and taking some of that fluid out, so all that pressure is just gonna come right down and you're gonna have brainstem herniation. So that is why it's severely contraindicated. And I think I talked about the other one. Headache